Good morning, everyone. I should say hello because we should have people from India also. So, good morning, good evening. I'm Mrinalini Watson, President of the India Interest Group's Board of Directors. On behalf of the chapter, thank you for joining our community where cross-cultural exchange, thoughtful storytelling, and the power of ideas to travel across borders is nurtured. I will provide brief highlights of some of our events and programs before Dr. Jindal is introduced. I'm delighted to welcome you to the Visions and Voices series, where we will engage in dialogues across culture, health, and ethics. Our first conversation with Dr. Devendra Sharma in September introduced us to Indian opera. Today's session is with renowned transplant surgeon Dr. Rahul Jindal. In March, Dr. Elizabeth Kadetsky will discuss the ethics of artifact acquisition and repatriation. And in May, Dr. Rima Sehgal will help us understand how to create safe spaces. In addition to the Visions and Voices series this year, we are hosting a three-part virtual Chai Chat series. In the first session, we learned about the history of chai. In the second, we will share chai-related stories. And in the third, we will bring our chai memories to life through Haibun. We hope you will join us to share your stories and discover Haibun. If you struggle with any aspect of writing and artificial intelligence is on your radar, you might be interested in our Writing Mentor program. In November, Akshay Dalal, head of regional risk and compliance at Google for the Middle East, kickstarted our Writing Mentor program with a discussion on practical yet ethical ways to use AI in academic and professional writing. The Writing Mentor program is a one-on-one mentorship program that pairs writers with experienced mentors in a structured, writer-focused workshop model. If during the mentorship the team requires additional guidance with how to use an AI writing tutor and other tools, they can arrange to have a session with Akshay. To register and receive details about the program, please submit the form at the link that's shown here. Finally, I'd like to invite Fulbright filmmakers, both current grantees and alumni, to submit their films about South and Central Asia to our second annual film festival. The submission deadline is January 30th of next year. Films will be streamed from April 18th through May 9th. Q&A sessions with the filmmakers will be on May 2nd and 3rd. There is no application fee, and we hope many of you will consider submitting or sharing this opportunity within your networks. For submission details and to apply, please complete the form at the link provided. These initiatives and programs reflect our commitment to not just telling stories, but crafting them with care, intention, and impact. We look forward to your participation and hope you will join us in amplifying voices, expanding perspectives, and deepening global understanding. The India Interest Group's Director of Communication, Dr. Nirja Vasisht, will now introduce our keynote speaker, Dr. Rahul Jindal, and the moderator for this session, Kyle Patel.
Good morning and good evening, everybody. Thank you so much for being here. I just want to confirm, Dr. Jindal, are you able to hear now or no?
Not with my headphones, but can you hear me now?
Yeah, we can hear you. Okay, I just wanted to
Okay.
make sure because once you start, I want everyone to be able to hear you. Okay, thank you so much for being here. I have the great honor of introducing everyone to Dr. Rahul M. Jindal. He is currently the professor of surgery, preventative medicine, and biostatistics at Uniformed Services University in Bethesda, Maryland. He also serves as commissioner to the Human Rights Commission for Montgomery County, Maryland. He has received 3 Fulbrights over the years, his first being the Fulbright Nehru Distinguished Chair to India in 2015 to 2016. He then went on to receive the Fulbright Nehru Senior Scholar Award in 2020. And his most recent Fulbright was the Fulbright Nehru Specialist Award in 2024. He also received the Great Immigrant, Great American Honor by the Carnegie Foundation in 2019. He's a world renowned transplant surgeon and holds a PhD in social psychology. In addition to all of his clinical activities, in terms of his research and etc., he has also notably set up the first comprehensive kidney dialysis and transplant program in Guyana, South America in 2008. He added the corneal transplant to the program in 2015. He has continued to work there over the years, and he's also working towards implementing his program in 15 CARICOM countries. His team also performed the first successful kidney transplant in Suriname, South America in 2019. Today, he's going to be talking about the Surgical Accredited and Trained Healthcare Initiative, SATI, and SEVA programs. The session will be moderated by Kyle Patel, who's a third-year medical student at Johns Hopkins University. He and Dr. Jindal met during their Fulbrights in India from 2021 to 2022 and have collaborated on multiple research endeavors together. They share interests in global public health, working in India, and have strong ties to the state of Gujarat. As an extra plus point, Dr. Jindal, Kyle Patel, Dr. Kapil Dave, Research Associate at CHP Department Seva Rural, and Dr. Dilip Mavalankar, Distinguished Professor of Public Health and former Director at Indian Institute of Public Health, Gandhinagar, will also be serving as expert speakers at our upcoming global health discussion titled Responsible Leadership in Global Health and Building Sustainable Healthcare Systems, Lessons from India, scheduled for Feb 28th, 2026. And on a personal note, I met Dr. Jindal when I was at the Fulbright conference in 2022 while I was wrapping up my Fulbright, and we shared a car ride to the airport. And in those 30-40 minutes, we talked about science, global health research, and all the work that he's done in India. So I know that this is going to be a treat. So Dr. Jindal, please take it away, and so everyone else can enjoy all of your insight in science and health.
Oh, thank you. Thank you for inviting me. So what I'm doing is to give you a range of activities we are doing. 10 or 12 years before the Fulbright, and then, as Nirja said, 3 Fulbrights in between. And I should count the 6 failures between the first Fulbright and not getting the Fulbright. So the global health work started about 25 years ago, and I started applying for the Fulbright about 15 years ago. And the first success was in 2015. So I'll just give you a whole range of activities we are doing focused on Guyana, Suriname, and Botswana, which was interrupted by the COVID. We could never restart. And the University of Oxford Summer School, where we teach. And Lindsay Baines is there from there. She's the director of the program, known her for about 30 years. So this is where we teach the global health diplomacy and all the work we are doing across the world. And then the Fulbright Nehru Chair, the SEVA program, and the NCD. So Kyle Patel, who co-authored the publication with me on decolonization, and we'll try and focus on that. We both have roots in Gujarat, in Ahmedabad. So he's second generation and I'm first generation. So I give you a little personal reflection. So I've been very lucky to get my Fulbright in where I was working and where I was born. And I was born in New Delhi, but I was brought up in Ahmedabad. And as kind of the stars, as you say, coincided that I got the Fulbright right there in Gujarat, in Ahmedabad. And when I went there first in 2015, I could actually live in my own family house, which is quite rare. Now, people in Ahmedabad across the world don't really knew Ahmedabad or know Ahmedabad till Prime Minister Modi became the prime minister, because that's his hometown as well. And of course, Mahatma Gandhi, who started his landmark epic struggle for independence, is right there. He started his Dandi march from Ahmedabad, and his ashram is on the river Sabarmati, which is quite and you'll see some of the work we are doing has connection to the Sabarmati, because the slums are on the bank of the river. So this is my first Fulbright at Bija Medical College. That is my alma mater. So I was kind of quite fortunate to get the Fulbright Award right there. That's the leadership presenting the award to me. And the second was at the Indian Institute of Public Health, Gandhinagar, where I am an adjunct professor, and Dr. Mavlankar, the current director. Uh, Now, this is a very important institution for those who are doing public health, because it is India's first university dedicated to public health. And the entire university has different departments and biostatistics, social work, with a lot of different things. So I just want to kind of point out, and all the work is centered around Indian Institute of Public Health in Gandhinagar, Gujarat. Gandhinagar is a twin city, so the distance between Ahmedabad and Gandhinagar is about 22 miles. And it used to take, an hour, but now there is a metro and you can go there in 10, 15 minutes. And now this is my third Fulbright, which the new director, Deepak Saxena, so Dr. Dilip Mavlankar, actually is all connected somehow, because Dilip Mavlankar was a medical student when I was a resident in Bija Medical College. And I worked under his dad, who trained in the UK. So you have all these connections. And this is where we were there. And then my training, as I said, in Bija Medical College, University of Oxford, where now I teach this course in global health diplomacy every year, Boston and New York. Now the Fulbright gives us the prestige to be able to, and the connections to be able to collaborate, for example, with Nobel laureate Farid Murad, the University of Stanford. So he was here in George Washington before. My medical team, which consists of personnel from different, not just my university, but from Drexel University, from SUNY Downstate, and the nurses come. So we come together and create this program. So it is not an institution. And as I'll show you before, we don't have a hierarchy. We are a loose affiliation. So we call it a public private partnership. And of course, nothing without the people we work with, both in Guyana, Suriname, and in India. And our work is engaging the community by community meetings, or we call them town hall meetings. And that's how we engage the community. And we have very good access. We can go in the slums, we can go. Something very interesting came into my mind is some of the people I work with here, they were asking, could you do all this work if you were not of Indian origin, or if you were Caucasian? That's a very difficult to answer. Is like, because I speak the language and because of the color of my skin, I can go anywhere and mingle and be able to get the work done. So I have not been able to find an answer to that question. Now, what is decolonization? And Kyle and Dina, we wrote this publication. So I'll center my different facets of global health work, which I call it pre-failure, pre-applying for the Fulbright, applying for Fulbright for 6 years, then succeeding. So I got three Fulbrights. Now I'm applying for the fourth one. But there are certain problems with the Fulbright is you have to wait for 2 years before you apply for the next one, and you never know whether you'll succeed or not. And the work you have started could stop or could discontinue. So it's very important to continue the work. And to continue the work, what I've done is to create an NGO, my own NGO in Maryland. So that's my wife and I, my wife is an internist, and we put together a certain amount of funds from a salary into the NGO so the work can continue, hoping you get the next. And the other problem with the Fulbright is it doesn't support infrastructure and it doesn't, so it just supports me, which is good enough. But so this is the definition of decolonization. So everyone is talking about decolonization is addressing white supremacy, commercialization, privilege, and so on. So what we are doing in Guyana, Suriname, Botswana, and in India is empowering the local people to take the work while we are not there, or eventually we want to become, uh, redundant, so-called. So, what are the goals of decolonization? Is encourage the oppressors to relinquish powers and empowering the oppressed communities. So, you will find in the slums, we are empowering the local community by training community health workers. And the community health workers, the key foundation of the work is that they have to live within the community. So they cannot commute from outside. Now, Ahmedabad is a metropolitan area of 8.5 million people. It is spread over about 25, 30 miles. So just like New Delhi, it's a NCD, or they call it, Greater New Delhi and so on. But the core is that we train the local. So in Guyana and Suriname, we have trained the local surgeons to become transplant surgeons, kidney transplant, cornea transplants, without fellowships. So it is power sharing, or it is decolonization. So, what are the theoretical underpinnings of decolonization? So, I've used an Indian word, seva. So, this is what we believe in: is selfless service, uplifts others through solidarity and not charity, and morality. So, we just had a paper coming out in BMJ Global Health, which is currently a high impact journal. Was right. So we created a pyramid, and we said, there are different facets to it. Some are politically incorrect now, like DEI and so on, and health and human rights, universal health coverage, and eventually moral clarity at the apex. And and what we believe in is task shifting. So everyone knows that the WHO definition of task shifting is rational redistribution of tasks. So this is what we are practicing, and we are doing all our work through a PPP rather than an NGO. So these are the advantages. So there is no one president of the work, or there is no one director. It's a loose affiliation which comes together for the task. So I show in Guyana is to create a kidney transplant program, and then a cornea transplant program, and in India to create the Sati program, or the community health worker program. So this is where the story starts in kidney transplant, part one. And as I said, this is during the application for the Fulbrights about 20 years ago. So this is, I call, probably more successful when I failed to get the Fulbrights. So this story starts when I was in New York about 20 years ago, working in Brooklyn in SUNY Downstate. So one of the very well-known and well-to-do Guyanese American called George Subraj, he picks up a flyer. So everything starts because the stars align, and because it's going to happen in the Indian sense, it's like karma. And so he picks up this flyer, and I don't know him. I meet him in a Indian restaurant in Brooklyn. He shows me, he just starts talking, and he says, "You want to come?" There he is. Um, that we want to do something in global health which will last for a long time, because before the kidney transplant program and the cornea transplant program, he used to take teams of doctors and distribute medications and treat diabetes, hypertension like a medical mission. But it really didn't work. It wasn't sustainable because the medicines would be sold on the black market. There was no follow up for diabetes, hypertension, and so on. So the people who went felt good, they got certificates. But at the end of the day, he thought it wasn't sustained. So he wanted to do something which will leave a lasting legacy. And George came from Guyana as a quintessential success, American success story, without any education. And he built up this entire empire of 20,000 apartments. So I put together a team from Drexel, from New York, from where I work, from Walter Reed and Uniform Services, NIH. And the very important part is we always work with the government, whether it's Guyana, Botswana, or in India, because that's the only way it can be sustained. Otherwise, it becomes fragmented and there is no success. Otherwise, it depends on me or the team. So we have to have some sort of a political input in the work we are doing. Just tell you a little bit about Guyana. Guyana is a small country. It was a Dutch colony, then a British colony. It's the only country which speaks English. It's an English-speaking country. Half the people from Guyana are of Indian origin. They came 8 generations ago. So that's the Indian connection for the Fulbright. And this is the person who was asking for funding. And Guyana did not have dialysis at that time. And this is something you would want to know is very expensive dialysis, kidney transplant, or heart surgery, or brain surgery, and so on. A kidney transplant costs about $500,000. This is probably the most important slide for those who are doing global health is the Honorable Minister of Health, Dr. Ramasamy, who was trained in the US. He went back to Guyana to try and make change. And he said, so when we first went to Guyana with the team, he says, if all kidney failure patients were to be treated with dialysis or kidney transplant, 70% of the budget would go to provide these services. And what about HIV, diabetes, typhoid, cholera, and so on? So you guys should leave us alone, really. There is no need for treating a small number of patients. So he would rather see them die than do anything. So that's where we come in with the benefactor who completely funds or funded the entire program. So we have done 33 trips and now they are doing it independently. Each trip is about $25,000 and then setting up and teaching. And as you can see, and there's another India connection is generic medications. They have to come from India. As you know, India supplies, it's the pharmacy to the world. If we had to take branded medications, and I'm not promoting generic or branding or whatever, is it would cost about $20,000 per year for the anti-rejection medications if we were to get from one of the pharmaceutical companies. So generic medications from India, if we set up a pipeline through the government. That's why the government comes into the picture. They have to approve, and you get it for $1 a day. It's the same situation for HIV, anti-HIV medications in South Africa. So setting up and dealing with licensing issues and so on, and all patients cannot be transplanted. So there is some element of ethics in it in patient selection. So we do our first kidney transplant. So after 3 years of groundwork, of education, infrastructure, and so on, we set this up. And the first kidney transplant involved 23 people in the team. So you'll be surprised, it's not only medical staff, but we also took an attorney with us, a US attorney, in case we have some licensing issues or legal issues. And this is the Minister of Health now saying he raises the standards across. And I'll show you later on how we have learned. So it's very important to analyze the results and see if there are failures and to write it up. So we found that in phase two, we had more deaths than expected. And this was basically because of non-compliance. The patients lived in remote parts. So we were concentrating in the tertiary part in Georgetown, which is the capital of Guyana, and in the main hospital. But we forgot that the patients live in the hinterland, in the forested area, and so on. And they had trouble coming into the tertiary hospital. So we set up, that's where I learned the importance of community health workers. So we set up community health workers who would go into the remote part in the Amazon and so on, and actually see the patients. And this is the elements of successful kidney transplant in low and middle income countries, generic medications, patient outreach, involving the political leadership, and so on. And of course, quality assurance. So once we did the kidney transplant, we trained the local surgeons and we analyzed the results, made the improvements. And the next thing was we saw a lot of patients lining up in the eye clinics. And we said, well, why is that so? And the answer was that because the local surgeons were not trained in simple procedures like cataract extraction, they were damaging the corneas and causing cornea scarring. And then, of course, trachoma and vitamin A deficiency. So we approached cornea transplant surgeons in the US who worked with us, and they said it wasn't feasible to set up a parallel cornea transplant program. Um, but the difference is the kidneys have to be taken the same time, donor surgery, and then transplanted, while corneas can sit in an eye bank for 3 months. And the need for corneas in the US has decreased because of seat belts, and there's no vitamin A deficiency, and there's less trachoma or almost no trachoma, and the speed. And the speeds are important, the speed bumps and so on. So 30% of the corneas were wasted in the US. They're lying in the eye banks and they're not used. So my team and I set up again with the government, both sides, with the US government and the Guyana government, and later on with the Suriname government, is how we can take the corneas across international boundaries. And now they have a full-fledged cornea transplant surgeons, and these are done by general ophthalmologists. The same kidney transplants are done by general surgeons. So then this is where I got the Fulbright scholarship, and then I was asked to address the 15 ambassadors of the CARICOM in 2015 and see how we can create a hub and spoke system. So each country in the Caribbean basin cannot set up these programs. So what we did was we extended the program to Suriname, and we did the first kidney transplant. And now they are doing more kidney transplants and cornea transplants. And the patients from other countries are sent to Guyana under an exchange program. So, moving to Botswana, the government of Botswana invited me to see if we can replicate the program we did in Guyana and Suriname. And I was there twice. Unfortunately, the COVID interrupted our mission. It has been put on hold because the effect of COVID has really decimated the health system of the countries. So just to give you the results of the first part, is they've done over 100 kidney transplants. They are now doing it routinely. The local surgeons have taken over complete. They're completely empowered. All we do is now telemedicine, and we have compared the results of the transplants, both kidney and corneas, done by the American surgeons, by my team, versus the local surgeons independently, and the results are the same. There is no difference in the outcomes. The other problem, which I mentioned about not only Fulbright, but Peace Corps and others, is a lack of continuity and lack of infrastructure development. So when the scholar goes and does the work, which is all well and good, but there is no infrastructure development because there is no funding. So USAID used to give funding for infrastructure. It doesn't exist anymore. But then there was no coordination between USAID, the US government, and the Fulbright Scholar. So from your experience, you could say a little bit more later on, is that the Fulbright Scholar goes and does the work, teaching and so on, but there is no infrastructure development. So my benefactor, George Subraj and his foundation and my own foundation, so we said this shouldn't happen. And you can see we have upgraded, with the help of the local governments, we have increased the dialysis chairs, we have set up an MRI machine, an operating microscope, and so on. These are very difficult for an individual scholar. It has to be done at an organized level, which we have succeeded. Now, so this is the time I got my second Fulbright, and and learning from previous experience in Guyana, Suriname, Botswana, and so on, is we really need to concentrate on creating a cadre of community health workers. And that's the only way you can take the task forward. So with Dr. Mavlankar, who's there in the center of the screen, we thought that there was really a need for unmet surgical need. So kidney failure is one, cataract is one, but then there are 200 unmet surgical needs which need to be addressed. So as we all know that the world is experiencing a chronic shortage of well-trained health workers. So this exists in sub-Saharan, it exists in India, and India is a different type of disparity is between urban and rural. And in the urban, there's a real problem where the slums are neglected. So you have high rise, you have malls, you have metros, and so on. But under the highway or under the metros or on the banks of the river, you have massive concentrations of urban slums, which are completely dissociated from the mainstream. And this is creating a political problem as well. So, this is what we thought. And I put the protocol to the Fulbright for my second and third, and I was successful, saying that there is a gap and we want to concentrate on the poorest, the slum dwellers. And it was a politically challenging decision as well, because everyone thinks that the rural or the tribal areas, so-called, need more attention. And I'll show you why that may not be there. Now, the task of was the two objectives of my second and third Fulbright is to study the effectiveness of Ayushman Bharat. So Ayushman Bharat is a Hindi word, but basically Modi Care. Just like Obama Care, people call it Modi Care. It's a national initiative by Prime Minister Modi in 2017. And there are many opponents to it as well, similar to Obamacare. They may be right or wrong, but it has created two class of politicians in India, those who support Modi care and those who don't. And basically, it means it's a significant step towards achievement of universal health care and sustainable development goal 3. And we wanted to see the effectiveness of surgical task shifting. So this is, we came up with the acronym because Sathi, we need an acronym to succeed in India. Like Sathi means Sakhi or a friend. Otherwise, people don't kind of connect. And the same, it's like ASHA workers. Everyone who has been to India will know what ASHA, ASHA, means light. But they are one of the very successful community health programs in India. and it is widely acclaimed, about 10,000 publications. People go from all over the world to study the Asha movement. And there are downsides and there are problems with it as well. So we created, or I created with Dr. Mavlankar, this Sathi program. And these are volunteers who help people to obtain surgical care. And the basis is that they have to live within the slum. And we wrote a number of publications about the concept. And as I'll show you, there are 5 steps to it. We are currently on the 6th step, and this is the river. So you'll see the river is nice. There are walkways around, there are gardens around, but then there are also slums. And the slums they look like this. And and we have a publication on the tribal villages as well. And I'll show you what we started with. So my first Fulbright in 2015 is to study the baseline, is to see the burden of surgical problems and the level of unmet need. So whenever you want to start a project, you have to study the baseline and then see whether there is a problem or not. Maybe the problem has been resolved, maybe it hasn't. So I spent 4 months just studying this with partnership with Dr. Mavlanka and the Indian Institute of Public Health and so on. So we hired postdocs and Dr. Vora, who was the other professor, and out of 10,000 population in over 2,000, 3.5% of the people needed surgery, and I've highlighted this, and 116 people did not avail surgery, and we call them unmet need. And the very surprising part of it was that 100% of these people had gone to a physician to seek surgical help or a consultation under Modi Care, under universal free healthcare system. So some of it is working, but roughly 50% did not take the next step and get the surgical procedure, be it cataract, be it menstrual disorders, be it kidney stones, and so on. So this was an eye opener, and the paper got published, and a lot of people across India asked us to talk about this problem and say the financial reason. So when we asked the people, is the next slide to it, is we did focus group and individual surveys, and they said financial reason. But that's not true, because that could not be true, because Modi Care is totally free. But then lack of trust or trust deficit was a major problem. And you'll see how we try and resolve it. So the conclusion was that Ahmedabad or Gujarat is a relatively high income metropolitan, but still 50% are not using the Modi Care. So we did a cross-sectional survey as well, because we were told, or by the Indian Institute, by the local physicians and so on, that you should go into the hinterland, go into the tribal areas and not in the urban slums. So we said, let's do a scientific study. So my second Fulbright was basically on this section, is comparing the tribal area. The tribal area is an area called Sabarkantha. It is 150 miles from Ahmedabad on Gujarat-Rajasthan border, and it is a fairly poverty-stricken area. However, you can see from this slide that the unmet surgical need was 5% versus 40% in the urban slum. And the reason is the high priority given by the government of India on social deprivation, and also the NGOs. These are the NGOs from the Gandhian time, 100 years, and they are done a really good work in concentrating their work or taking care of the tribal and the rural poor. I think Kyle Patel could talk a little bit more, because he worked for 9 months in the in the tribal area. So we said the step three was we really need to understand why people are not using Modi Care. Similar to the Medicare or the Medicaid issues is the lack of trust. And this is the study which I personally spent 2 months doing. Is although people needed surgery, 3.5%, there was a major trust issue. And this is probably easier to understand is the perception of quality and using a standardized instrument. And you can see they score very well, 90%. But patients were concerned that the hospital workers don't talk politely to them. So, not talking politely upsets the people that they do not get the kidney stone or cataract done and so on. And the doctor gives me good treatment. You had only 41% score, while the rest is, I think the doctor is very learned, 99. I admire the doctor, 98, and so on. So this was again an eye opener. And based on our on the work we did so far, 4 out of 10 persons who were advised surgical care did not avail, even though the treatment was free. So this is probably the most important is we created this cadre called Sathi, the community health worker program. We devised a curriculum and we said we cannot treat all the 200 patients, 200 surgical problems. We'll concentrate on the top 5 surgical problems, which is extremity wounds, kidney stones, cataracts, abdominal pain, including external hernias and menstrual disorders. And we designed a modular curriculum. And this is so each Sathi worker has to deal with 5 to 6 unmet surgical needs per month. And this is the publication. This is the modular rough curriculum. This has been validated. Lindsay Baines helped us with the psychological part. She's here on the screen. And now we have given this curriculum to over 100 Sathis, the community health workers, and we have also started training the ASHA workers. So this is another positive step is the government of Gujarat has allowed us to give the curriculum to 60 ASHA workers. So ASHA workers, their main job is prenatal and antenatal care, but we want to see if they can also be taught to deal with the 5 common surgical problems. Now, these 5 surgical problems are unique, and that's what learning point is may not be common in Orissa or New Delhi or West Bengal or South India. So you have to do baseline studies to see what the 5 common surgical problems are. Now, diabetes, hypertension are all over. There's an explosion, but this is very unique to Gujarat, to the slums. And this is what they do, the Sarjis, the Satis skill set. But they also taught to measure blood pressure and blood sugar. So this is a unique aspect. And this is the implementation. So my last Fulbright, which is a year ago, and I should point out that in between the Fulbrights, the first, second, and third, we have continued going to Ahmedabad, also because it's my hometown and I went there anyway. But I continued the work. We appointed MPH postdoc students to continue the work and a structure. So led by Dr. Maulankar and Dr. Kranti Vora. There's a very strong Johns Hopkins connection. Kyle will want to know that they all trained in Johns Hopkins and went back to India. So whether it's Maulankar or Kranti Vora or Keur or most of them. So it's just a coincidence. So this is the 6-month pilot which we analyzed. And this is what it is now. So in between the Fulbrights and continuation, we got funding from the Hinduja Foundation, which is a very powerful uh, Indo-British family, and one of the um, effects of Fulbright is that you can take your work and talk to people, and you get access to them. So the pilot was 2022. Um, we did 12,000 people, 60% conversion rate. So I've highlighted this. 60% means from unmet to met need. And there is a benefit in terms of quality of life, in terms of employment, in terms of increased productivity, because this you're talking about people who are daily wages living in the slum. So phase one, we recruited 14,000. In phase two, we recruited 40,000. Currently, we aim to recruit 60,000. So 12,000 households, and we have already completed 6,000 households. So it's moving very rapidly. And we are also going to replicate this in Pune. There's another city north of Bombay. We have selected a slum where we'll be, because just doing it in one city is not enough. So we have to show, and the Hinduja Foundation insisted we show that the principles of Ahmedabad can be replicated in another city. Now, to be clear that we cannot go to every slum in India or in Nigeria or Botswana, wherever. So we are creating a model, we are creating a curriculum, and we have written publications and talks like this. And then those who want to replicate it, they can make changes based on the local conditions, and then it's up to them to fund it and so on. But we can help them in. So there is also clear, this is one of the studies which was done by a postgraduate, an MPH student locally, and he showed that there was clear benefit in health related quality of life. So the Sathi program showed 26.14 points increase in the health related quality. So those who are in deep into public health will understand this, and this is the propensity score. We have just sent this entire publication to JAMA. We'll have to see whether they accept it or not. But it's a very intense, detailed work on a subcategory of patients who benefited from the Sati program and those who didn't. And this is what the next phase is we are extending it to Pune. We have got more funding. We plan to cover 350,000 people, so which is very big. We plan to train 25 sathis and 5 supervisors. And the last part is important, that the community came and told us that it shouldn't be totally free. You have to start charging a small nominal amount, which will increase compliance. So we wrote this up, and the fee will be decided by the community. So they'll decide what you want to charge. Uh, so, for example, 50 rupees to measure blood pressure, 100 rupees to measure blood sugar, because you have to require strips and AccuCheck and so on, and wound care. The wound care will be 200 rupees. So this is decided by the community, and we are studying this process. We don't know whether it will be successful or not, but it's something we can discuss. Now, I just want to talk to you just a few slides on decolonization in terms of, and Captain Patel, again, is a senior nephrologist and a Navy captain, retired, who works with me. And he has roots in Baroda in Gujarat. And he said there is an explosion, which we know, of diabetes and hypertension. You can see from the slide. So what he did was he created SEVAK, another community health worker program, to screen the villages for diabetes, hypertension, obesity, and lifestyle modification. So there's another offshoot, And he and I came up with this idea, and this is what the Sevaks do. So you have now ASHA workers and you have the Sevak workers. Now, the Sevak workers are in 400 villages. So that's a much bigger program than the Sati program. And it is being implemented in 4 states of India. So it is in Maharashtra, it is in Orissa, it's in Tamil Nadu, and in Gujarat. And this is, so I won't go into a lot of details, but we have a number of publications. Is the prevalence of hypertension was 29.4%, obesity was a problem, and smoking and tobacco use and alcohol was an issue. So the same figures for diabetes. We are detecting about 10 to 12% people who did not know they had diabetes or hypertension. And we showed both for Sathi and the Sevak program that they can reliably collect data, they can put it in iPads, and it can be analyzed, and the model can be replicated. So other states in India are already replicating the program. I'll quickly switch to protocol curriculums as well, because many of the curriculums taught in India and in low and middle income countries are based on Western textbooks. So Professor Subramaniam's a good friend. She passed away now, but she was a professor at Indian Institute of Technology, Gandhinagar. IITs are again pretty well-known institutions in India. We thought we should create a credit course for non-medical, non-nursing students to learn about diabetes and hypertension, the health literacy curriculum. You can see from the slide that this is what we did. We hired a postdoc, Ankita Shah. She did an entire PhD on this, is to create these curriculums based on the Indian conditions. And this is based on interactive sessions, debates, hands-on training, and it has 6 credit points. So this was important, and she did this study, and which we wrote it up, Shah Jindal Subramaniam, on effectiveness of health um, promotion curriculum, and basically doing a pilot first, and then doing a intervention group, comparing it with a non-intervention group. And we think this is the first study in the Indian context that addresses NCD-related health literacy in a randomized trial. And this is now being replicated in other states in India. So the Fulbright gave me access to advocacy. We have access to the ministers in Guyana, Suriname. We have access to the president of Guyana, the prime minister of India, and Mr. Arun Jaitley, who passed away sadly. He was the finance minister of India. And we have been able to advocate and press to the health attaché and the military attaché in the Indian embassy in India. And this is General Chopra, who's head of the military services in India. So this gave us the opportunity to tell our story of what we are doing. So to end, this is the last slide, is the definition of global health is evolving. And should decolonization be included, racial reckoning, Me Too, rural health? So urban health, rural health, but within urban health, my work is mainly slum health, slum surgical health, and within it is task shifting. So empowering the surgeons in Guyana to do specialized work and empowering the communities to train in community health and community health workers. The basis of community health workers is they're only 8th grade educated and they live within the slum, and they are able to do all this, collect the data, and we are able to write it and advocate for the surgical issues. So that's where I end, and I'll have the floor to Kyle Patel, who also worked in Gujarat, not very far. And our first meeting was at the rooftop, right? Agassi restaurant.
Yes, yes. Or was it? I don't remember if it was the conference or
Did I meet? Yeah, I met you at the conference in New Delhi as well. We
yeah,
didn't have time to talk much there.
right, right. But it was great catching up after. But thank you, Dr. Dindal. This was such a great presentation and very informative about your work. I have many questions myself, but also if anyone has other questions in the chat, please send them. But I can start with one of my own, which is maybe more like personal and my own interests, but you started off as a medical person. You went to medical school and then you became a surgeon and then you really got involved in a lot of public health work. So what was that kind of transition like and what did you always want to do this kind of global health, public health kind of work, or is it something that came up afterwards? What influenced you?
So I always wanted to do global health, but I never trained, I never did an MPH. I did MBBS and MS in India, and in England I did FRCS and a PhD. But I was always interested in the social and the economic part of it. Because my PhD is in psychosocial issues, not in pure science. We wrote a book as well with Lindsay Baines here on quality of life, improving quality of life. But then quality of life can be improved only by community work. So by doing, to answer your question directly, by doing a kidney transplant or cataract, you help one patient, one at a time. But by doing global health, you have a much wider reach. Um, this was my thinking, and I got involved with it about 25 years ago, even though there was no support as such. But then sometimes the stars aligned. I did not have to struggle for funding, which is um, which happened, and the Fulbright added to it. And as I said, the Fulbright doesn't give money funding for the infrastructure, uh, but it gives the aura, or it gives the kind of credibility to be able to go out there and do the work and attract funds.
Yeah,
I'm very poor at biostatistics, and I take help from others because I never did an MPH. I
right.
never did hardcore biostatistics.
Yeah, but you've collaborated with a lot of people.
Yeah. So we have collaborations with, like you and I wrote the paper on decolonization. And so, each one brings their own strength to it. Like Lindsay Bain, she's a hardcore, psychologist, social psychologist. Most of my work is collaborative. Uh, that's why I kept saying Indian Institute of Public Health, Gandhinagar. It's an entire institution with maybe 40 faculty and 200 MPH students. So we collaborate with them, or I collaborate with them. Um, there's no way it can be done in isolation. If you want to have effect on the policy, or legislature, um, and we have access to, as I showed you in some pictures, to maybe chief minister's office or the minister of health. So eventually, you need to have political change, legislative. So what we are doing is a very small part. So we found, for example, that people don't trust the Modi care. They had trust deficit. So although it's out there free, but patients are living with a cataract or with kidney stone and losing their daily wages, losing employment and not getting the procedures done, which are right there, 2 or 4 miles away from their slum, wherever they are living. So we have to bridge the gap. Um, and working with the political leadership, they have allowed us to train 60 ASHA workers into our curriculum and see what happens, whether it can be extended. As I said, we cannot do this single-handed in a million villages in or slums in India or Sri Lanka or Pakistan or Kenya. So all we can do is to create a model and with the support of the local political leadership, take it to other cities, which we are doing. We are taking it to Pune in the next few months.
Yeah, that's awesome. And I guess that kind of leads to my next question, which is like I think you've done a wonderful job of showing how to like go in and collaborate with the local community because that's a huge part of decolonization as we've discussed. But you still have this identity as an American, an Indian American, and you grew up in India, so you have a unique position. But I guess how do you grapple with being someone who comes from the West and is still going and working in these places? And has that led to any challenges?
So that's, as I mentioned, when I give my ethics course at the uniform services, many of them will ask, like, if you were Caucasian or would you be able to do this? It's a very difficult, because, and I forgot, I'm a British citizen too, because I trained in the UK for 10 years and came here. So I have dual nationality. So I don't know what they accept me as. Like when I go to Ahmedabad, I speak fluent Hindi and Gujarati.
Right.
Um, because we came from New Delhi and settled in Ahmedabad when I was 5. So I speak fluent. I don't know. It's a very sociology and mind. I don't know if different. Lindsay can answer this question. She's U.S. British born, trained in U.S. and worked in India with me quite a bit.
Um, it's interesting because maybe you read my mind because I was going to ask Kyle if I might say a few words, just having watched Rahul develop me as a protege over the years. Is recently I was it was my turn to give the address at our graduation, and I spoke about opportunism and about informal opportunities come your way. For example, Rahul talked at the beginning about how he met Nirja in a taxi. Okay. And so it's not only these kind of formal, sort of calculated, planned meetings, it's also about opportunities that come your way and being willing to put yourself out there and start conversations with people. And you never know where these conversations are going to end. Because I don't think that Rahul really divides himself up into, I think he sees himself as a global citizen, really. But, just getting in a cab and start talking to someone, and one thing leads to another. And sometimes it's just these opportunistic chance meetings. And that was the case between George Subrash and Rahul. But it was very chance. And it's just about these meetings, these opportunities come to everybody, but it's about being willing to just start a conversation and to think out of the box and to think across lines that leads to the difference between things happening and not.
So just
Yeah.
to put it in another personal, both my kids are physicians. My son is a radiologist and my daughter is a pediatrician, married to a urologist, but married to other Indian Americans, but they have no interest in global health. And so it has, you know, they understand Hindi, Gujarati, they go to India and all. So it has, I don't know what drives someone to do global health or um, it's,
Yeah.
I mean, you always debate whether it's ingrained, whether it can be taught, like seva, the seva which I mentioned. or selfless service? Can it be taught, or it is innate? It's just there. You're born with it.
Yeah, probably some combination of both. Mm. Okay, I know Nirja, you had a few questions that were more like technical. Do you want to ask one of them?
So you asked
Y-
about females. So I had a number of slides. Is that the females did not avail of Modi care as much as males, and the elderly and the unemployed did not. Um, and we looked into in the focus groups is why females, and uh, they said they have to take care of the housework in the slums. They have to do the cooking, they have to clean, they have to take the kids to school, and so on. So they did not find the time. And one of the jobs for our sathis, the community health workers, is to accompany the patients to the hospital and save them time, and to get the testing done and CT scan and follow up. Because if you go to a public hospital in India, there are always about 1,000 people waiting outside, and some of them wait for 4 to 5 days to see a physician for a consultation. And many of them get frustrated when they have to come back for the test. I mean, the same thing here. This care is fragmented. You go for one thing, they tell you to do another thing, and then a third thing, and so on. So that's what they do, the sathis, and it is a problem. The For centuries, a millennium, the females have been oppressed in India, and female empowerment is a major area it needs to be looked into.
I think my other question kind of relates to this because you mentioned how the women are like, oh, we have to do the housework and stuff. So, and earlier you'd said that some people cited financial reasons for not getting the surgery, but Modi Care is free. Do you think like these are they say financial reasons, but they mean like time cost, right? Like, oh, if I go to the hospital today, who's gonna
Hmm.
cook for my child? So I will have to pay
Hmm.
somebody to do that. So maybe the financial reasons aren't about getting medical care specifically, but maybe other costs related. So I don't know, you mentioned the Sati worker, like going with the person to the hospital, but I don't know if like, no, like if you get the rickshaw or the auto rickshaw, like do you have, like, do they pay for that out of pocket? Is the transport cost too much for them, depending on what the distance that they're traveling versus if they're working, like they're going to lose that day's wages. And is that too much of a cost? And that's why they're saying financial reasons. I don't know if you looked into like why the
Yeah,
financial reason term
yeah,
gets used by a significant portion of the people.
yeah. So because I couldn't cover everything, so we have created a cooperative within the slums, and they have to pay 1 rupee a day to offset the financial cost of hospital. So these are daily workers, daily wages. So to offset the cost, there's a menu of charges they can get from the cooperative. So 5 days in the hospital, they will estimate, the leaders of the cooperative will estimate the loss of wages and the loss of, or maybe hiring someone to take the kids to school or do the cooking, as you said. Um, so there's a lot of thinking and a lot of other things which have gone into the success, which cannot be measured in a publication. It's not like statistics, but we have created a cooperative to help with this. And I did not mention that the religious leader. So many of the slums are Muslim dominated. Some are Hindu. Now, as you know, there is a traditional animosity of the Muslim community against Prime Minister Modi in Ahmedabad. In 2002, there were massive riots, which made international news, which made Prime Minister Modi a pariah in US. He was denied a visa, and I mean, Fulbright is not to go into the politics of, but uh, some of the community health workers are specifically selected because they are Muslims and they have better rapport with that part of the community. And the religious leaders are very important as well in the slums. They have a very tight control. It is loosening with the internet and so on, but that is, and we go out of the way. You saw one slide where actually I'm going into a Muslim dominated area and talking with them. Um, so there are a lot of other facets which go on while I'm not there. And that's why collaboration is important, because we have a social worker called Falguni who will go and talk to them. Um, the integrity of the data is important as well, because when the data is collected by the community health worker, there's no paper, they are taught on iPads. And the data goes to Indian Institute of Public Health, where it is analyzed daily. So if there are some numbers which are too close together, like blood pressure readings and sugar, the social worker will go and to them or accompany them to see if the machine was calibrated, if there was any problem, cheating, and so on. The other thing is the community health workers have CME as well, and they have a multiple choice question. Um, no one is failed or passed. If they get, say, 5 questions wrong on multiple choice, then the social worker will sit down with them and go over did you miss the eye exam? Did you take wrong blood pressure reading? If the glucometer was calibrated correctly or so on. So um, that 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 is also difficult to put it in a publication. But someone asked an interesting question about Sarabais. Yeah, Sarabhai is a very big, well-known name. Sarabhai, one of them was the founder of the atomic plant. The was and Mrinalini Sarabhai, who was a classic dancer.
Hmm.
She was my class fellow in St. Xavier's College. So
Wow,
her
that's amazing.
connection goes back. But, you may not recognize me now, but whenever she comes, she send a cell phone that, but I haven't really connected with them because, but
Yeah,
uh,
Malika and Kartikaya are still in Ahmedabad. I
yeah,
was there on
so,
a Fulbright to compare tap dance to Indian classical dance.
so, um, Malika Sarabhai went to college with me. She's the
Oh,
same age I am in St. Xavier's College in Ahmedabad.
ah,
And then we kept sporadically in touch, but I haven't really, but it's a good thing you pointed out. The next time I go to India, I will connect with them.
yeah. I taught her students how to tap dance.
Oh, wonderful, wonderful.
Yeah, I brought taps there instead of my book allowance,
Hmm.
and I gave the taps out.
Hmm. So Ahmedabad has given rise to some of the very big industrialists like Ambani and Adani and Sarabhais,
Hmm.
and they have all been very um, indirectly supportive. None of them have been, and of course, the sway of Prime Minister Modi in Gujarat he has a very tight grip. And I have known,
Nalini used to correct my table manners.
oh, with
When
a
to
hand
use my left hand and my right hand.
like interesting thing about Zoran Mamdani, he was criticized because
Oh
he was
yeah,
eating with his hand. And
right,
not knife and fork, because you can't eat dosha and sambar with a knife and fork.
right. We always ate with our hands,
With the hand,
even the upper class.
even with the, yeah. And Prime Minister Modi. I've known him since I was in college. He was 6 years ahead of, but like we don't throw his name around because we work with the grassroots. We work with both
Right.
communities. And the Indian Institute of Public Health has been very supportive. Um, it is getting collaboration and losing, you know, showing them that you really care. It's, selfless service. So publications is good. We need publications because that's the only way you can create a model. Because if you don't have publications in high impact journals, it's as if you have not done the work. So
Right.
you have to work across the board in publications, in helping the MPH students. And as I said, I didn't have MPH and I'm not good at statistics. So I collaborate with different people.
Right, right. Okay, so we have maybe about 5 to 10 more minutes, so maybe a couple questions and then we can wrap it up. One of them from Sherilyn is about your decolonized curriculum. What was the outcome of that? And
So
how?
we wrote it up. We did the randomized studies. We had Ankita who did a PhD. The
Okay.
next step, and we're giving 6 credits. So not I, but the Indian Institute, the IITs will give 6 credit points to someone in first year.
Mm,
As you know, IITs are very well known.
right.
Some of the biggest names like Sundar Pichai and I don't know, they all went to IITs or the World Bank, Ajay Banga, and so on. So they have a big reputation. So I don't know how many students will take up the curriculum. And we are going to put the curriculum on an app as well. So I found the funding to put the entire curriculum, theoretical as well as practical, in an app. So unless it's an app, people don't use it. That will cost some money, but we'll do it. And then we'll have to see how many engineering students will enroll. It's very early because we wrote this just 2 years ago. It took 4 years to do the study. Um, so time will tell, but I'm sure, we think about 10% of the students who are interested in health sciences will take up this 6 credit points.
Okay, wonderful. Well, again, thank you so much, Dr. Jindal. Do you have any last concluding comments you would like to give?
So someone asked about liver transplants.
Yeah.
That's a very, very expensive and time consuming and helps a few patients. So it's not as common as cornea transplant or kidney transplant. So kidney
Mm,
transplant is more common because kidney failure is more common because of explosion of diabetes and hypertension. So if you control prevention of diabetes and hypertension, you won't have the end organ damage. As the Sevak program Captain Patel is doing, he has been extremely successful. He retired now and he spends 4 months in India every year training, and his curriculum, his 5 day in Baroda, where he attracts, the American Heart Association has sent representatives and the British Kidney Foundation and so on the curriculum and what they do. And he takes these visitors on field visits, and so they can follow the community health worker into actually what they are doing in a practical way. So that is, so liver transplants, unfortunately, right now, if someone gets a liver transplant, if they cannot be airlifted to US, they will die of liver failure. But then, there's Hep B vaccine is controversial. Now USAID is not going to support HIV and Hep B vaccine. So
Right.
I don't know what's going to happen there. But then the other side of the story is that we were creating a dependency culture. So
Hmm.
they have to become self-sufficient. Um,
Right. There's a balancing of different
there
priorities.
is a balance. So when I was in India in college, we used to have Peace Corps workers come in. And
Hmm.
then because of political tensions, they stopped Peace Corps workers. And they measured the effect of not having Peace Corps or USAID on Indian policy. And the results are mixed. You know, a lot of people came up is that it reduced the dependency on Western. It made India truly decolonized, which I don't know what, you know, there are a lot of Fulbrights who went to India,
Hmm.
um, what they think about the success of not taking US or, you know, development aid.
Hmm. I think that'll be a great thing. Our next panel in February about global leadership in public health. Well, again, thank
Mhm.
you so much, Dr. Dindal. I think that's all we have time for today. Um, is there anything else you wanted to say, Mrinalini or Nirja?
No,
So
this is
someone asked
absolutely
a
wonderful.
question about how many people distrust Modi care. So, you know, I have a publication and I showed this one of the slide. Um, is 60% of the people, based on a focus groups as well as individual surveys, did not trust Modi care because a misconception that they would be sent into um, public hospitals where untrained residents or residents in training, you know, you have a similar situation here as well, is, you know, they don't want to go to a public hospital or because they think residents will be operating on them without supervision. So a similar situation with Modi Care. But you see, Modi Care is just like 6 years, 7 years down, and things are changing. Maybe it will never change. Maybe they need to make modifications. And a number of panels are looking at modifications of Modi Care is now they are forcing private hospitals, what they call multi-specialty hospitals like Apollo hospitals and big healthcare systems, um, to accept Modi care, even if they lose money. So we'll see. I mean, that is another study which needs to be done. Sorry, I interrupted you, Nirjan.
No, I think we do need to let everyone go. It's been absolutely wonderful hearing from you this morning and or evening for everyone else. Um, and I think if anyone, I think there might be a couple of questions that we may have missed, so please reach out and we can connect um, you to Dr. Jindal so you can get his email and kind of ask your questions. And of course, please come to the global health discussion that we're holding on Feb 28th next year. And you guys can ask any leftover questions then as well.
So Dr. Mavlankar will be on the panel, and Dilip Mavlankar, as I said, is the face of public health in India. He is one of the most recognizable, um, and one of the answers is in India, you need to have some report which goes back many years. Like I studied surgery under his father, and he was my medical student. It goes back 50 years. So I don't know, these things can be recreated, you know, family ties and cultural ties. And
It's quite
it
difficult.
is the nature versus nurture theory, you
Ex-
know, is.
All right. Thank you again, Dr. Jindal. Good to see you.
Thank you, everybody.
I should end with a namaste.
Yep.
I always end my lecture with a namaste, even in the US.
Yes.
I was giving I was giving a lecture to Mittal Institute in Harvard recently, you know, with 117 people. And I was in Ahmedabad that time, and they asked me to end it. I ended it with a namaste. And they were saying, yeah, that is truly Indian now.
Namaskar, namaste.
Namaskar.
Namaste. Okay. Bye, everyone.